Hi, I'm Mandeep Singh. I'm an anesthesiologist and sleep physician, associate professor in Department of Anesthesia at University of Toronto, and I'm also the current president of Society of Anesthesia and Sleep Medicine. Thank you so much for this collaboration between SASM and the European Society of Regional Anesthesia, and many congratulations as we celebrate the occasion of the World Day of Regional Anesthesia and Pain Medicine, because regional anesthesia is one of our key tools in the armamentarium as it plays a key role in improving perioperative safety, especially for patients with OSA. Now, in this segment, we'll focus on analgesia, regional anesthesia, and post-op monitoring from a practical perioperative perspective. Question number 3, analgesia and pharmacology, simplification versus reality. Opioids are often treated as a single risk in sleep disordered breathing, but opioid pharmacology is far more nuanced in the perioperative setting. Different opioids vary in duration of action, active metabolites, and context-sensitive half-time, such as remifentanil versus morphine, for example. Therefore, it becomes especially relevant once doses accumulate of longer-acting opioids, especially that are administered systemically, and patients fall asleep. Now, patients with moderate to severe obstructive sleep apnea or limited ventilatory reserve are particularly vulnerable to these effects. Therefore, the goal is opiate stewardship and not blanket avoidance, with attention to dose, timing, agent selection, and intentional integration with regional anesthesia techniques such as peripheral nerve blocks, neuraxial analgesia, neuraxial opioids. All of these options reduce systemic exposure to opioids, limit overnight accumulation, and therefore improve perioperative safety in patients with OSA. Question number 4. Postoperative physiology and monitoring, the nighttime blind spot. Postop monitoring is important, especially in these patients. It should be risk stratified based on physiology and observed events rather than the location alone. It's important for us to recognize PACU respiratory events defined by the presence of repetitive apneas, bradypneas, oxygen desaturation, and patients having pain sedation mismatch, the presence of high pain scores in the setting of high sedation scores. These are early warning signals and not failures of care. Their presence should prompt escalation, including enhanced monitoring for hypoxemia, hypercarbia, or hypoventilation in the post-op period, reconsideration of discharge locations such as hospital admission or ICU admission, their absence in the setting of a stable analgesia and ventilation patterns, often supported by effective regional anesthesia techniques, would support routine ward care. The goal is not universal ICU admission, but rather matching monitoring intensity to the physiological risk, particularly when these patients are falling asleep and in the immediate post-op period. Question number 5, systems, pathways, and futures of care. Peri-op OSA care is moving away from one-size-fits-all pathways towards physiological risk profiling. Traditional metrics like AHI do not fully capture perioperative risk in this vulnerable windows. Phenotyping, wearable monitors, and AI-based tools are really promising, but at the present, as more and more data is evolving, these pathways that would integrate these tools may actually matter more than just one wearable monitor. Therefore, these tools should augment and not replace clinical judgment. And if they're embedded within solid perioperative care pathways, that would actually be more thoughtful and more meaningful for these patients. Question number 6, practical clinical takeaway home messages. What are your top 3 pragmatic tips for anesthesiologists managing undiagnosed or high-risk OSA patients in day-to-day practice? If there was one key takeaway from this discussion, it's this. Perioperative risk in OSA is driven less by diagnosis itself and more by how we manage sleep, opioids, and the respiratory physiology. And regional anesthesia is among the most effective tools we have to modify that risk. Therefore, what are the top three things? First, assume vulnerability during sleep, even when patients appear stable while awake. Second, use regional anesthesia deliberately, peripheral nerve blocks, neuraxial techniques, neuraxial opioids. All of these options reduce systemic opioid exposure, decreasing side effects, and preventing accumulation of opioids in the post-op period. A particularly important message on the World Day of RAPM. And third, plan beyond the operating room, recognizing that post-op risk is actually emerging not just at the time of exposure, but can continue after PACU discharge, especially in the immediate post-op period. Last question, referral and long-term care. What are the most important red flags that should prompt referral of a peri-op patient with suspected OSA for further evaluation or long-term management? Peri-op events offer a critical window into undiagnosed or untreated OSA patients. Red flags would include recurrent PACU events, witnessed upper airway collapsibility under sedation, for example, or emergent from GA, marked sensitivity to sedative agents or opioids at any point in the perioperative window. Patients with moderate to severe OSA, particularly if they are more vulnerable, have conditions such as obesity hyperventilation syndrome, pulmonary hypertension, or low pre-op oxygen levels should all be considered for a formal perioperative evaluation and management plan. And therefore, if we get sleep, opioids requirements, and the respiratory physiology right, the regional anesthesia don't just manage pain, but they meaningfully change perioperative risk in patients with obstructive sleep apnea. This is Mandeep Singh, current president of SASN, saying many congratulations on the World Day of Regional Anesthesia and Pain Medicine. Thank you very much.
Hello, my name is Philip Kurian, and I'm an anesthesiologist and also a dual credentialed physician in sleep medicine. And I practice both anesthesia and sleep medicine at the University of California, San Francisco, and at Zuckerberg San Francisco General Hospital. And I'm a member of the Society of Anesthesia and Sleep Medicine, SASM. And we appreciate the collaboration between SASM and ESRA. This segment is dedicated to the topic of obstructive sleep apnea and regional anesthesia and perioperative safety. And here are our thoughts on some burning questions. We often hear that patients with obstructive sleep apnea are always high risk, but that statement is rarely precise about what risk, under what conditions, and compared to what. So, high risk for having obstructive sleep apnea could mean high scores on screening questionnaires. There are two categories of these patients, those with undiagnosed or suspected obstructive sleep apnea and those with known OSA. These patients who have moderate to severe obstructive sleep apnea are at higher risk for cardiovascular morbidity in the perioperative period, especially when they remain undiagnosed and untreated and unmonitored. Other high-risk groups are those with obesity hypoventilation syndrome, pulmonary hypertension, and those with low baseline oxygen saturations at presentation. The risk increases in combination with opiate medication and other CNS suppressive medications, and that is where regional anesthesia techniques can actually reduce risk. OSA is frequently treated as an independent perioperative risk factor, yet much of the observed risk reflects the interaction between obesity, opiate exposure, sedatives, and surgical stress, rather than apnea alone. Most perioperative identification relies on screening tools rather than objective sleep testing. Commonly used screening tools include the Stop-Bang questionnaire, the ASA checklist, and the Berlin questionnaire. And really, no single tool is better than any other tool. It's just what is more compatible with your preoperative screening workflow. These tools are designed for high sensitivity, which is appropriate for screening, but they have lower specificity. I think the major pitfall is that you equate a positive screening result with confirmed moderate or severe obstructive sleep apnea. What the screening tools really do are they estimate probability, but not equate to disease severity or physiologic reserve. Another pitfall is ignoring clinical context, including baseline oxygenation, cardiopulmonary disease, and anticipated opiate exposure. From an SASM perspective, perioperative risk should be viewed as a continuum rather than a binary diagnosis. The more useful question uh, is not does this patient have obstructive sleep apnea, but what physiologic vulnerabilities does this patient bring to the perioperative period? Regional anesthesia with deep sedation is often assumed to be safer in patients with obstructive sleep apnea, but that assumption deserves scrutiny, and really more high-quality clinical evidence is needed to confirm this assertion. Deep sedation can result in airway obstruction, hypoventilation, and hypercapnia, particularly when the airway is unsecured and respiratory monitoring is limited, which is really what happens outside of the operating room. That being said, in the operating room itself, with a patient under constant observation by a trained anesthesia provider, airway obstruction should be managed appropriately. But this may not relieve all respiratory event types, rather, and thus may not completely eliminate risk. In selected patients, a controlled general anesthetic with a secured airway may provide more predictable physiologic control than deep sedation that's layered onto regional anesthesia. This is not an argument against regional techniques, but a reminder that technique alone does not determine safety. SASM intraoperative guidelines emphasize minimizing respiratory depressant medications, ensuring full reversal of neuromuscular blockade, and maintaining vigilant respiratory monitoring. And these principles should extend into the postoperative period for a patient with suspected or known moderate to severe obstructive sleep apnea. Intraoperative decisions should be individualized based on physiology, monitoring capability, and surgical factors rather than default assumptions. The first few postoperative nights often are when patients are most vulnerable to respiratory depression, yet monitoring intensity frequently decreases after PACU discharge. Postoperative sleep architecture is altered. REM sleep can be the most vulnerable window for OSA patients, and REM rebound actually increases in the first 2 to 3 days postoperatively, and that extends well beyond the first postoperative night. But residual anesthetics, opiates, and supine positioning can worsen sleep disordered breathing in any sleep stage and can occur even in the first postoperative night. The idea that apnea only occurs at night does not mean that daytime naps are safe. Sleep combined with sedatives or opiates can reproduce the same physiology at any time, although REM sleep can be reduced during daytime napping, and REM sleep can also be depressed with opiates. SASM emphasizes that perioperative risk, and specifically postoperative risk, is tied to sleep state rather than to clock time. Physiologic vulnerability often emerges during sleep, even though the patient appears stable while they're awake. The Stop Bang questionnaire, the ASA checklist, and the Berlin questionnaire remain practical and accessible screening tools. No single screening tool has been proven to be better than another, but one tool might be more applicable to your perioperative screening workflow than another. Their strength lies in their sensitivity, but clinicians must recognize the limited specificity of these tools. It is important to note that screening tools do not equate to OSA severity. If a patient is found to have a high screening score and demonstrates clinical behavior consistent with OSA postoperatively, patients should be counseled and a referral for appropriate outpatient evaluation and treatment is warranted. If a patient has significant comorbidities such as obesity, hypoventilation syndrome, pulmonary hypertension, and low preoperative baseline saturation, they may not be appropriate candidates for ambulatory surgery, and preoperative optimization should be considered for all of these suspected OSA patients if compatible with elective surgical timelines. Screening results should prompt planning and vigilance, not automatic labeling or exclusion. Interpretation must always be paired with clinical judgment and physiologic assessment.